Now, moving on to some of the ligamentous injuries of the hand. We'll be briefly discussing in this section what are the different hand ligamentous injuries. As we have covered mainly the carpometacarpal dislocations, metacarpophalangeal dislocations, phalangeal joints, interphalangeal joint dislocations. These are all one of the bony fractures, although there are always associated ligamentous injuries with that, and this usually results in sometimes ligamentous repair as well. But sometimes it's not only the bony, it looks an x-ray, it looks everything normal. There's isolated ligamentous injuries, which is although very common as well, especially in the case of the hand. In this section, we will be briefly discussing the proximal interphalangeal joint ligaments, which can get ruptured and injured as well. Then the metacarpophalangeal joint, what are the ligaments which involving that and how they can get injured as well. And then lastly, we'll be discussing a very important component which is called the ulnar collateral ligament of thumb at a metacarpophalangeal joint. There is a specific term called as the gamekeeper's thumb or the skier's thumb, and that is due to the deficiency or damage or the injury to the ulnar collateral ligament of the thumb. And we will be discussing in details what are the different pathanatomy, pathophysiology of the gamekeeper's thumbs and how we can treat and manage this disease. Now coming to the proximal interphalangeal joint ligaments. If you see over here, this is the metacarpal heads, and then this is the proximal phalanx, in the middle phalanx, and this is the distal phalanx. The proximal interphalangeal joint surfaces are actually over the at the proximal interphalangeal joint level, and they are more marked over the volar surface, and they are more thickened over the molar surface, forming a palmar plate. There could be a partial or complete tears of the proximal interphalangeal joint. Usually partial tears are not much of a worrisome because they overheal and fibrosis occurs. But if there's complete tears, this usually results in a forced angulation of the joint, and it could lead to either displacement volarly or dorsally. But most commonly, as the volar side is quite thick, but usually this hyperextension injury can lead to dorsal displacement of the middle phalanx, leading to the rupture of these, complete rupture of the proximal interphalangeal joint ligaments, especially over the volar side. Mild sprains require no treatment. As I told you, partial injuries usually require no treatment at all. But if there is a severe injury, that is either complete rupture associated with the fracture dislocation as well, then you can keep the finger which is splintered in extension at least 2 to 3 weeks. Now it's very important to know whether an x-ray, if everything is still normal, but the patient has swelling, highly painful, and increased laxity of the joint as well. Therefore, most likely the proximal interphalangeal joint are disrupted or ruptured. And then you have to keep the finger in splint and extension for at least 2 to 3 weeks. Then after 2 to 3 weeks, we can start mobilized with neighbor splinting to finger adjacent to the ligamentous injury. It's important that we cannot keep it for prolonged immobilization as well, because there's a hand and it gets stiff very much quickly, and stiffness of hand is highly problematic. Therefore, once we do keep it conservatively for at least 2 to 3 weeks, but as soon as the 2 weeks or 3 weeks pass, we quickly start the range of motion exercises so that the joint does not become stiff. Especially the flexion and extension exercises are started, and over the distant interphalangeal joint, over the proximal interphalangeal joint, as well as the metacarpophalangeal joint as well. Now, if the joint is fractally unstable, and we know that we may have to get on x-ray would be absolutely normal, we may have to get an MRI and to see how much the injury is actually to this is there. And if it's frankly unstable, occasionally we have to repair it. But then again, another point comes in whether we can repair it or not as well. Sometimes we can simply repair the ligament. Sometimes we may have to go for ligament reconstruction, because then repair is actually not possible. Occasionally, the bone to which the ligament is attached is actually avulsed, but when that happens, actually we know it's a fracture dislocation. But if that has not happened, which is although very rare, that means the isolated fractures, isolated actually ligamentous injury has to be repaired or reconstructed. If the fragment is markedly displaced, it can be simply reattached. That is the bony fragment we're talking about over here. And if you see Metacarpophalangeal joint dislocations is, we have discussed the interphalangeal joint. Now coming to the metacarpophalangeal joint. If you see, this is the hand, these are the metacarpals, and the metacarpophalangeal joints are actually found at the, when the heads of the metacarpals articulate with the proximal interphalangeal joint. These are involved the index finger, middle finger, ring finger, and the little finger as well. The most important is actually of the index finger, where the metacarpophalangeal joint of the, actually this is called as the radial collateral ligament of the index finger, which is the most vulnerable. Although the injury of radial collateral ligament is very rare, but if it occurs, it's the most commonly which occurs at the metacarpophalangeal joints injuries. Tension of the ligament is tested when the metacarpophalangeal joint is flexed. You ask the hand and you check the radial tension. If it is lot of subluxation of the joint, or there's a lot of laxity in the joint, this means likely the radial collateral ligament is actually injured. In children, it is more easily seen, because X-rays are available, and usually X-rays show a Saltaris type 3 injury, in which the fracture line is going from the physis into the epiphysis. And if there is a Saltaris type 3 injury in children, you must suspect there could be an isolated or associated radial collateral ligamentous injury as well. If there is a large bone fragment and displaced, what we should do, we simply it has to be reattached to the via palmar approach, and once we ever reattach that, we can reattach in form of a K-wire and form of a screws as well. Or we can use a simple 2 K-wire and cerclage wire to create a tension band construct, or a small screw can also be used to create a tension band construct as well. If very small fragments are there, then they can be treated with splintage with the metacarpophalangeal joints flex. And usually it's a common position of the hand is this, the 90-degree of flexion at the metacarpophalangeal joint and extension at the interphalangeal and distal interphalangeal joint as well. So why this position is kept? So that the bone and ligaments are actually at the least stress and they can heal over time easily. Now coming to a very important topic called as the gamekeeper's thumb. Why it is called as gamekeeper's thumb? Have you ever wondered? Actually, this term was coined by Campbell in 1955, and what happened is, back in that time in Scotland, it was this kind of an injury was very common with the Scottish gamekeepers, especially those gamekeepers which were involved in the game of the rabbits. What they used to do was they used to hold the rabbit between their index finger and the thumb, and they used to break the neck of the rabbit with the applying of the force of their thumb between the index finger. If you see this, and I'm applying a force like this, my thumb is actually going into hyperabduction and extension, and this is what actually used to happen. This injury was very common in those gamekeepers, especially of the Scottish era, and what happened was actually doing this again and again, and getting in the doing this actually produced repeated stress over ulnar collateral ligament, and over time ulnar collateral ligament actually resulted in either there was a rupture or actually attrition of the ulnar collateral ligament, and leading to a classical type of injury called as gamekeeper's thumb or skier's thumb. Now why it is called a skier's thumb, I will be getting that as well. If you see, this is the thumb, this is the metacarpal, and this is the proximal phalanx and the distal phalanx. This is the radial collateral ligament attached on the radial side, and this is the ulnar collateral ligament which is attached on the ulnar side between the metacarpal and the proximal phalanx. If there is a force is applied in such a way that thumb actually goes into abduction and hyperextension, there's a lot of hyperextension in the thumb, this would produce excessive stress over the ulnar collateral side and would lead to rupture of the this ulnar collateral ligament, and this can result in an injury called as gamekeeper's thumb. If you see, this is in game 2, it has actually, this thumb has gone into hyperextension and abduction and leading to rupture of the ulnar collateral ligament. So that is why it was called as gamekeeper's thumb. Why the term skier's thumb was coined? Because the skier's thumb, it is also called injury of ulnar collateral ligament, but with the advent of skiing, especially with the high energy sports, when those skiers who fell with on their thumb or in the hand in such a way that when they were falling, their thumb was actually in abduction and hyperextension, and all the weight of their body was actually transmitted to this joint. This resulted in actually rupture of the ulnar collateral ligament. That is why it's another term is also, it's also called as skier's thumb sometimes as well, because the skiers usually especially they get the injury most oftenly. As I told you, it's seen skiers who fall on the extended thumb, which is abducted as well, forcing into hyperduction, leading to fracture of the ulnar collateral ligament or rupture of the ulnar collateral ligament. A small flake of the bone is usually pulled off at the same time. Now, sometimes the injury is so severe that this ligament not only ruptures, this ligament also pulls a very small bony piece as well along with it, which can be seen on the X-ray as well. There is a loss of stability which interferes with the pre-incisal pinching activities. And if this is the metacarpal joint becomes unstable, as I told you, the first and foremost problem would be the pinch. And if pinch is affected, actually it's one of the very important functions of the hand. And if that gets affected, the hand function can be severely compromised as well. Now, this could be a simple partial rupture. If the injury is not severe enough, as with the gamekeepers, this could be partial rupture as well, or it could be complete ruptures if it's a high energy trauma, especially with the skier falling on over his hand with thumb extended and abducted and all the weight of the body transmitting to the carpometacarpal joint of the thumb. This can lead to complete rupture, maybe with or without a bony avulsion as well. If the ligament pulls away from the distal attachment, it will not heal unless it is repaired. And if it does not heal, this means the carpometacarpal joint will remain unstable. And instability at the carpometacarpal joint would mean the pinch would be compromised. Therefore, the movements of the hand would be compromised. So how to test it clinically? There would be definitely tenderness. There is swelling precisely over the ulnar side of the thumb and metacarpophalangeal joint. As you see in this is the radial collateral ligament side, this is the ulnar collateral ligament side. If the thumb or the proximal phalanx goes in extension and abduction, this usually results in the ulnar collateral ligament injuries with sometimes a bony avulsion. A small piece of bony avulsion can be seen on X-rays as well. X-rays are actually done to exclude a fracture before the stress test. Stress test are why it is done because we need to whether it's a complete rupture or it's a partial rupture as well. And stress test is done by the thumb in extension as well as 30 degree of flexion. If there's increased laxity in both the extension and 30 degree of flexion, this means there is a more serious injury, and this means there is a lot of complete rupture has occurred. If with the flexion there is increased laxity, but in extension there is less laxity, that means either some fibers are still intact because the ulnar collateral ligament fibers actually attached to the palmar plate. When in extension we try to sublux the joint, then if not getting sublux, this means those fibers which are attached to the palmar plate are actually intact. And when in flexion we try to sublux the joint, this results in actually increased movement of the joint. But if it's happening in both extension and flexion, this means all the fibers which are actually involved, which are attached to the palmar plate and which are providing stability to the joint, are ruptured, and this is a more serious injury and which will require actually repair as well. If more obvious laxity, this means it's a complete fracture. So what is the treatment? Now the treatment actually based on the two things, either it's an acute injury or a chronic injury, plus it's a complete rupture or a partial rupture. If it's partial tears, and how we come to know about the partial tear? One is clinical method, other is we can get an MRI as well to see whether there's a complete or partial rupture of the ulnar collateral ligament. If it's a partial rupture, we can apply a cast or thumb spica, a thumb splint for at least a short period, 2 to 4 weeks of immobilization in the splint. This is the thumb splint. Thumb spica cast can also be applied as well, followed by increasing movement. And pain should be avoided for at least 6 to 8 weeks till the ligament heals completely. If it's complete tears, that would require an operative repair. And why it requires an operative repair? Because not to injure the superficial radial nerve branches, when we are opening it up, usually the incision is actually on the dorsal web space, and that is how we go in and repair it. And from this side, this superficial radial nerve branches are lying very close to the carpometacarpal branches, and they can get injured as well during they're almost lying in the line of incision. So we have to be very careful, especially when we're going for the repair of the ulnar collateral ligament. There's a term called a Steiner lesion. Now, what is a Steiner lesion? What happens is when ulnar collateral ligament ruptures, this can get entrapped into the abductor aponeurosis as well. And if it gets entrapped, it will not come back to its original position and will never heal by conservative measures. So even if there is no bony fracture, there is no complete fracture, but if there is a Steiner lesion present, and how we come to know that? We come to know by use of an MRI, whether the ligament is actually trapped into the abductor aponeurosis or not. If there is a Steiner lesion, then you have to repair it. There is no way it's going to get healed on its own. Aponeurosis is incised, and how do we repair it? Aponeurosis is incised and retracted. Torn structures are carefully repaired, that is ulnar collateral ligament, one end is repaired to the other end. And then the joint is immobilization in thumb splint for our thumb spica for at least 6 weeks. And thumb interphalangeal joint is left free from the outside. This is important that this joint is always free so that the movement can occur at the distant interphalangeal joint. And thumb splint or spica is applied up to this level. Once we have removed the abductor aponeurosis, repaired it, then we can keep the carpometacarpal joint immobilized for 6 weeks. And after 6 weeks, we remove the spica and start the range of motion. As much as range of motion can be done, therefore, it will cause increased rehabilitation of this ulnar collateral ligament. In this section, we will briefly go through the ligamentous injuries of the hand, which isolated ligamentous injuries are rare but can occur as well. Usually there are partial ligamentous injuries. There could be interphalangeal joint injuries. There could be metacarpophalangeal joint injuries as well. We briefly discussed the radial collateral ligament injury of the index finger, which is although very rare but most vulnerable. And we have also discussed very important entity called as the gamekeeper's thumb, which is actually ulnar collateral insufficiency. It is important that it's also called a skier's thumb because skiers usually get this kind of injury, and the initial management is actually depending upon whether it's a partial injury or a complete injury. Partial injuries can be treated conservatively with usually a thumb splinted in either thumb spica or thumb splint can be applied for 6 weeks, but for 2 to 4 weeks, and then we can start early range of motion. But if it's a complete injury and associated with Steiner lesion, then we have to go for open reduction internal fixation in form of repair of the ulnar collateral ligament, and then we can immobilize the carpometacarpal joint with the thumb splint or spica for 6 weeks. And after the removal of spica, we can start the early range of motion rehabilitation. Thank you very much. Keep watching sqadia.com.